Hello.
Yep.
Hello, everybody. Welcome. We have a number of people still joining. We're going to give ourselves maybe one more minute to start. Welcome. See, we have a few more people who are joining us. Maybe take a half a minute longer. I hope everybody's doing a good day, having a good day. It's really nice out here. A little overcast, but higher temperatures are always welcome. We're always happy here in Minnesota. So I think we can begin now. Hello, everybody. To those of you joining us for the first time, welcome to this Roundtable series, and to those joining us again, welcome back. This is the fourth installment of our series. My name is Elma Johnson. I am the coordinator of the Public Health Center of Excellence on Dementia Caregiving, and I also help coordinate the Center for Healthy Aging and Innovation here at the University of Minnesota. I'll be just introducing us and introducing us all to our presenters today. Next slide. Before we begin, we just want to ground us all in the fact that the University of Minnesota in Twin Cities is located on traditional, ancestral, and contemporary lands of Indigenous people. We acknowledge this, and with gratitude, the land itself and the people, and we commit through our action, teaching, and our work with community to learn and honor the traditional cultural Dakota values: courage, wisdom, respect, and generosity. All of these we hope you will see reflected in the work today. Next slide. Briefly, for those of you, I think most of you will be familiar with the BOLD, Public Health Center of Excellence and Dementia Caregiving, but we are a national level center, and our purpose is to support public health agencies nationwide, state, tribal, and local, in developing their dementia caregiving programming initiatives. We do that in several ways. First and foremost, as a dissemination center, we improve access to evidence-based programs, and really in days like today, in these events like these, we disseminate best practices, what we know works. We also act as a facilitator and convener, facilitating connections and collaboration among public health agencies and a variety of service organizations. And finally, thanks to our membership, which includes national leaders organizations who develop and disseminate tools to support and programs to support dementia caregivers, we are able to provide technical assistance to public health agencies around identifying, selecting, and implementing interventions that work. For a little bit of context, our center exists within the Healthy Brain Initiative Collaborative. Some of you might be familiar with it, but it is a group of partners funded by cooperative agreements with the CDC under the National Healthy Brain Initiative and the BOLD Act, Building Our Largest Dementia Infrastructure Act. And we together work to put forward collective solutions to brain health, to promote brain health, address cognitive impairment, and to support caregivers. I encourage you to scan this with the camera of your phones if you would like to learn more, and that will take you to our website, from where you can visit the websites of each of our members. Next slide. Before we start today's event, just wanted to let you take the opportunity that we have here to let you know that we have another webinar coming up. This one on June 12th will be on the topic of state dementia registries. and their value as a important source of data for public health agencies when it comes to planning and developing services for dementia caregivers specifically. So if you're able, please join us for that event. We'll have a great panel. So back to today. As I mentioned earlier, this is the 4th installment of our bi-monthly Roundtable series for public health. And in each one of these episodes, we tell the story of one state. Today, we'll be hearing about Wisconsin's work. And it is an opportunity for networking and really peer learning and idea generation among public health agencies and professionals. We're trying to really build a community of public health practice when we can all share successes and learnings and get ideas for action. As you have, next slide, please. And as you've noticed, this is set up as a Zoom meeting, which is done purposefully to allow for, Maya, can you go back to thank you, to allow for a networking, but with that, there's a couple of ground rules, a few ground rules, just to remind all of ourselves. Please mute yourself, and we encourage you to turn your video on so our speaker today and our team doesn't feel they're alone in the room. So please put your name and organization in your Zoom name and use the Zoom Q&A feature to submit your questions. You can submit them all throughout the presentation. We'll have time at the end to answer them, but you might find also that they are answered live. After the presentation and the Q&A time, if you would like to talk or ask a question, please raise your hand and only unmute if you are prompted. Use the chat feature to share comments, resources, and links. That's our virtual space to connect and network. So the Q&A for questions and the chat for everything else. And then we will share the recording, the slides, and all the resources shared in the chat later with attendees of today's event. And finally, we always welcome your feedback, everybody's feedback, when it comes to planning all of our programming and certain webinars like today. So please tell us about your experience. My colleague Maya is going to put in the chat a link for you to give us feedback. It'll take you to the survey about today's event. It'll be easy to find. It's right on top of the chat today. So before you leave, please click on it and let us know how we did. Next slide, please. Before we begin, also, let's get an idea of who all is in the room today. So Maya has launched a poll, if you can please respond and let us know who you are representing. It'll also help Kristen, our speaker, to know who all is in the audience. Lots of community organizations and service providers and public health agencies. Great, so yeah. Great, so about 40% are service provider organizations and 18% bold public health agencies. And the same 18% non-bold public health agencies. So a very good representation of public health here today. Thank you so much, Maya. Next slide. So next, I'm going to introduce very briefly our speaker. She will be guiding us through today's event. Welcome, Kristen Felton. She's a dementia specialist at the Office on Aging in the Wisconsin Department of Health Services. In 2006, Kristen began working at the department, and in October 2010, Kristen shifted from Aging and Disability Resource Center development in the Office on Aging and began her focus on dementia care systems and supports in the community. In her role, Kristen created the Dementia Care Specialist Program, about which you will be hearing today, and is directing a bold public health grant award from the CDC. And she also provides leadership for the Wisconsin State Dementia Plan. Also joining her in the background who will be her colleague, Kathleen Smith. Kathleen will be answering questions and also managing the Q&A. Kathleen O'Toole Smith is an outreach specialist at the Wisconsin Alzheimer's Institute at the School of Medicine and Public Health at the University of Wisconsin in Madison. Kathleen has been the BOLD Grant Project Manager since April 2021 in Wisconsin. Thank you both for being here. here I'm going to hand it off to Kristen. Next slide. And as you listen to Kristen today, think about which ones of the essential public health services the Dementia Care Specialist Program really supports, really stands out in. Wisconsin's work really covers all of these in one way or another, but today's program, the Dementia Care Specialist, focuses on these three areas that you see highlighted. Thank you very much. And without further ado, Kristen, it's your turn.
Thank you so much, Elma. It's really a privilege to be here today and to speak with this audience on the Dementia Care Specialist Program. I'm really excited to provide this information to all of you. Next slide, please. So a quick overview of what we'll be talking about today. I will be discussing sort of the background and the landscape that existed in Wisconsin that allowed for the Dementia Care Specialist Program to come into existence. Our opportunity to pilot the program and how that came about, the expansion of the program over time and how it was funded, and then to go into more detail to describe exactly what the program does. And that is provide a web of support for individuals and their family caregivers who are living in the community. I'll give some examples of the Dementia Care Specialist Program in action and share some of our lessons learned and some of the impact that we have seen in our state. Next slide, please. To describe how the Dementia Care Specialist Program began, I need to briefly explain the landscape in Wisconsin prior to the pilot. Several events created fertile ground in which to grow the idea of what community-based dementia support could become if given the opportunity. Many things were happening across Wisconsin's systems of dementia care. The Wisconsin Department of Health Services received grants from the Federal Administration for Community Living in 2009 and 2010 to explore new ideas and replicate evidence-based programs, which I will discuss in a minute. The Committee for a Wisconsin Response to Dementia was convened to develop a state plan, and an analysis of gaps and available resources across the state was performed. Also in 2010, two events involving individuals living with dementia and the crisis response system led to a state Supreme Court decision and a legislative study council. In 2011, a state budget shortfall in long-term care services created the necessity for new ideas to reduce Medicaid spending. All of this led to the opportunity for the Dementia Care Specialist Program to come to life. Next slide, please. Wisconsin has received several grants from the Administration for Community Living listed here that have helped to inform the Dementia Care Specialist Program as it was created and as it has grown from pilot to statewide program. In 2009, an innovation grant allowed for the development of our memory screening in the community program by funding the pilot study at the Aging and Disability Resource Center of Portage County. You'll hear more about Wisconsin's ADRCs a little later in the presentation. The pilot of the memory screening program was successful and led to the voluntary adoption and eventual inclusion of the program in all ADRCs, even prior to statewide DCS program coverage. Memory screening in the community and dementia-capable ADRC staff are now components of the Dementia Care Specialist Program. So the ADRCs are the Aging and Disability Resource Centers that are located in each of our counties. In 2010, the Department of Health Services received two grants to replicate an evidence-based caregiver support program and a multimodal intervention for people in the earlier stages of dementia. These grants led to the inclusion of evidence-based programming as a component of the Dementia Care Specialist Program. And in fact, the need to sustain those activities after grant funding ended was one of the catalysts for development of the pilot. Next slide, please. In 2014, DHS received two new grants. The first grant provided the opportunity to develop resources, including an online training for family caregivers on many aspects of providing care, including self-care, with videos demonstrating effective responses to common behavioral symptoms. The second grant and its supplement explored two evidence-based caregiver support programs looking at barriers to and facilitators of family caregiver participation in evidence-based programming. The results of this project informed the DCS program in expanding the range of evidence-based programs available to each DCS as part of a menu of options. In 2019, the Department of Health Services received a grant to replicate and evaluate the Dementia Care Specialist program itself. Due to the COVID pandemic, the implementation of the DCS program was delayed in its pilot sites, but has proceeded in a new direction. One site has not been able to contribute data yet, but we have a big reveal of some of the preliminary evaluation results from the other site, which I will share later in this presentation. Just a little tease, exciting stuff coming. Next slide, please. All right, back to 2011. The opportunity to find funding for the pilot came when our state legislature identified a shortfall in our long-term care system budget and asked for remedies. Many suggestions were made, including to expand the previously mentioned ACL grant-funded dementia caregiver support program, which has an evidence base of delaying institutionalization, meaning placement into long-term care facilities, for people living with dementia, delayed that institutionalization by an average of 18 months when the family caregiver was the one supported using that intervention. The proposed savings from delayed institutionalization was included in the package of responses supported by DHS leadership. And the Dementia Care Specialist pilot program received permission from the Secretary's office to proceed on June 29, 2012. 6 months later, the first 5 DCS began work. Next slide, please. In 2012, one of the 2 events I mentioned regarding people living with dementia and crisis that occurred in 2010 had made their way to the state Supreme Court. The Helen EF decision, denying the use of the most common crisis response statute for people living with dementia, sent systems into chaos. In 2013, the pilot of the Dementia Care Specialist program began, and a legislative study council was convened. The Department of Health Services held a summit to create the Dementia Care Systems Redesign Plan later that year. Held at the end of October, one of the recommendations from the summit was to create dementia care navigators. And funding was found based on those recommendations to expand the Dementia Care Specialist pilot from 5 positions to 16. Funding was expanded to create dementia care specialist positions for 3 of our 11 federally recognized tribes in 2015. And at this point, all of this funding had come from underspending in the Aging and Disability Resource Center budget, which is a state-funded program that you will hear more about a little later. In the 2017 to 2019 state budget, the program funding shifted to inclusion in the biannual budget allocated to the Department of Health Services and increased the number of positions to 24. And as you can see, the legislature at that point has slowly expanded this number until you get to our current biennium, where funding was expanded to go statewide, covering all counties and all 11 tribes. Next slide, please. So the Dementia Care Specialist program is described as being constructed of 3 pillars, but I don't want you to think of silos. I want you to think of the program more like this image of a spider's web. The image represents the program in several ways. The 3 pillars of the program all work together and are all interconnected. And the program builds person-centered support around that person living with dementia and that family caregiver and their families as a unit in the center, surrounded by community. The web also represents the dementia care specialists themselves in the middle who cannot do it alone. All the other water drops are community partners, volunteers, businesses and civic organizations, neighbors and friends, so that no matter where you go in the community as a person living with dementia or a family caregiver, there is support available along that journey. Next slide, please. The first pillar is creating a dementia-capable agency. Next slide, please. The dementia care specialists are housed in Wisconsin's Aging and Disability Resource Centers, which have a contractual relationship with the State Department of Health Services. Expectations for the position and the agency are outlined in the contract. These include training for customer facing ADRC staff to be knowledgeable enough to recognize when a customer may have cognitive issues or a need for caregiver supports and can respond appropriately. All staff must be aware of the dementia specific services and resources available in their service area to promote appropriate referrals. Those same ADRC staff are also expected to provide memory screening when appropriate. The dementia care specialists oversee the memory screening program at the ADRC and provide training to the staff. The memory screening in the community program is intended to promote a conversation about memory or cognitive concerns. The outcome of the screens and the observations from the screener in the appropriate result in the appropriate encouragement by ADRC staff to speak to their doctor about those concerns. Memory screens are offered by the ADRC upon request in a variety of venues and are always voluntary. Our data demonstrate that people want access to memory screening, with 1,922 screens performed in 2019 before the program was statewide, but also the last good year of data. People really want to have access to have cognitive screening. And screens can be done in a private room at events like health fairs, as part of dementia-friendly community or educational events, or when indicated while ADRC staff are providing other services. An example would be a husband is struggling to prepare meals for him and his wife when she has always been the cook, but is no longer performing that role. So he contacts the ADRC to sign up for Meals on Wheels, and an appointment is made. While talking with the couple, if the ADRC staff member notices that one of them may have some confusion or memory loss, they are able to offer the screens as a part of the visit. It may not have occurred to him that his wife may have dementia. And if the results of the screen indicate that she should talk to her doctor about the changes, he may take action to assist her in getting a diagnosis sooner than if that conversation had not happened. Connecting people with their physician includes sending the results of the screens to the physician's office with permission. And participating in screening and what happens with the results is entirely up to the customer. Slide, please. Memory screening also happens at health fairs alongside bone density tests and blood pressure readings and other common screens. This helps to normalize memory screening and promotes the fact that the diseases and conditions that cause dementia are a medical condition. And that would help to reduce the stigma that goes around dementia. And knowledge is power. And the earlier in the process, the disease process, that everyone knows what is happening, the easier it is to make plans and prepare family. The screens used in the program are really conversation tools. They promote discussion of topics that people may be reluctant to discuss. And information provided as part of the conversation can be tailored to be specific to the concerns of the person and their family members at the time in that moment. Resources and available supports are also discussed as a part of the program, providing them with the knowledge that there are supports that are available out there. Next slide, please. The second pillar is for the dementia care specialists to act as a catalyst to create dementia-friendly communities. Next slide, please. Dementia is a highly stigmatized condition that can carry shame or guilt, both for the person living with the disease and for their family caregiver. The symptoms of dementia are something that many people do not know how to respond to, so instead they look away. Couples will lose lifelong friends. The caregiver may feel embarrassed by symptoms and stop going out as a couple. And both individuals can become more withdrawn and even isolated as the disease progresses. Dementia friendly communities are ones that are continually working to make their communities welcoming and inclusive of people living with dementia and their families. People living with dementia spend the majority of time with the disease living at home in the community, much of it pre symptomatic and possibly while still employed. The progression of Alzheimer's disease is estimated to last, on average, 10 years from the onset of symptoms to death, but it can be more. People generally do not move into care facilities until the middle or later stages of the disease process. So during the majority of time living with the disease, people will continue to do the things they always have done, including patronizing local businesses and going to their favorite places. Dementia friendly community activities include training these local businesses to be dementia friendly. For most businesses, such as grocery stores and restaurants, this is a customer service training on how to recognize when someone may have cognitive challenges and how to respectfully support them in purchasing goods and services. For other businesses, such as banks, a more sector specific approach is necessary. Information would include what to do when they suspect financial abuse may be occurring and what agencies and resources in the community are available to help. Law enforcement and first responders and other crisis providers are also a sector that requires specific training beyond basic customer service. Dementia friendly training goes beyond businesses as well. Libraries are great partners for local dementia friendly coalition meetings. Local government, including City Hall, where tax payments are collected, are also included in dementia friendly community trainings. Parks and nature centers, museums, religious organizations, civic organizations, recreational venues, concert venues, the list goes on and on. The dementia care specialists can also create opportunities for people living with dementia and their families to stay engaged in their communities, including memory cafes, which you will hear example of later in the presentation. The limitation the dementia care specialists have in providing dementia friendly training is that they cannot train medical practitioners or staff in long term care facilities, so not nursing homes and not assisted living facilities. DCS are not clinicians themselves, and dementia friendly training is not appropriate for clinical professionals. Next slide, please. But that doesn't mean there isn't plenty to do, because a dementia care specialist is only one person and can only do so much in a day. The creation of local dementia coalitions is an important component of this pillar. Building a dementia coalition local to a community, whether it's a neighborhood, a city, or an entire county, will be the engine that drives dementia friendly community activity. Based on experience, coalition members will do the majority of the legwork in more populated areas, less so in more rural areas. There are people who care about dementia across all sectors of business and local government. The reason is that 1 in 10 people over age 65 has dementia. That means the other people in their family know someone living with dementia, may care a whole lot, and some will want to do something to help with the struggles that they see their loved one experience. Or having received support, they will want to give back. These family members and friends work in all sectors, and they want to be able to contribute. The recruitment of Dementia Coalition members can come from anywhere. And through this coalition, the work of dementia friendly communities is carried out by the group, which extends the reach of that individual dementia care specialist. And as you can see, the description on this slide provides other examples of what happens with dementia friendly community work. Next slide, please. The third pillar is supporting people living with dementia and their families to be able to remain living at home as long as they would like. Next slide, please. You heard in the discussion of the Administration for Community Living grants that the results from those projects informed the inclusion of evidence-based interventions in the Dementia Care Specialist program. It is true that when I first created the pilot structure, it was not only to contribute to the cost savings plan, but to provide sustainability for those programs as required of grantees. So to this day, those programs are a part of the Dementia Care Specialist program. Other options have been added, and the current requirement of the program is to have at least 2 programs available, with one being an evidence-based caregiver support program, while the other can be an evidence-informed program for either the family caregiver or the person living with dementia or both. And many dementia care specialists offer more than just 2 programs. As they become more experienced, they add more options to their toolkit. In addition to the structured programs, dementia care specialists also meet with individuals and families one-on-one. Many families come to the dementia care specialists because they are in crisis. Something unexpected has happened, something the family cannot manage and needs assistance to deal with the situation, typically involving a medical event or a change in behavior. Once the crisis or crises have been resolved, then the family can decide to enroll in a structured program or an education program, a support group, a book club, dementia friendly outings, decide whether to access any of the additional resources from the Aging and Disability Resource Center or other community partners to provide support and assistance. Next slide, please. Now, I encourage you for the next couple of minutes to take a look at these questions and please put your responses in the chat. So the questions are, do you have a role similar to the dementia care specialist in your state? And if yes, please share your answer and any links that might be supportive in the chat. The other question is, do your community health workers work with older adults? And if so, what do they do regarding dementia and family caregiving? So please take a couple of minutes to think about those questions, and you can pop your answers into the chat. So yes, we're getting caregiver and dementia program specialist for age options, providing Alzheimer's disease education in the community. Some agencies level community health workers to provide dementia-specific supports. Senior Service Associates offers ADRD respite for unpaid family caregivers and also have memory cafes. Wonderful. We will be hearing more about those 2 things a little later as well. So there's also something similar to dementia-friendly work happening. Alzheimer's education in Alaska. Caregiver specialists are relatively new, but they are there. Yes, Hawaii, community health workers for giving training for memory screening. Shout out to Hawaii. AAA in Tarrant County. Yes, and there are also some that do not have the ability to have community health workers focused on older adults or dementia specifically. So I'm seeing many comments about memory screening and dementia-friendly community work. Yes, comments about funding, and funding is definitely a challenge. Work through our BOLD grant. Excellent to hear. Grants are wonderful opportunities to take steps. And respite funding, yes. Wonderful. All right. I think we could probably move on to the next slide. So the dementia care specialists also provide education and outreach about brain health, dementia, of course, and caregiving to a very broad audience. Wisconsin has a public school curriculum available from our Department of Public Instruction. And some dementia care specialists partner with the local schools to promote brain health through the Advocating for Brain Health skills-based unit for middle and high schools. This unit also talks about caregiving because kids are family caregivers too. It's something that I don't think we often think about as a reality, but I was one of those kids as a teenager and even younger who provided care for my grandfather. Nothing complicated, but when I spent time occupying him, I was providing care to him. And so kids are absolutely family caregivers as well. So please keep them in mind. Caring for grandma after school, or perhaps mom has young onset Alzheimer's or another type of dementia with onset in middle age. Whether it be working with students or helping a family caregiver deal with the grief of losing their spouse, dementia care specialists work with people in the community across the lifespan. Because even though age is the number one risk factor for Alzheimer's disease, the impact affects people throughout the lifespan because it affects an entire family. So, whether someone is interested in learning more about lowering their risk of dementia at age 35 because their parent was just diagnosed, or if someone needs to figure out how to deal with this one thing that their spouse with dementia keeps doing, or making the difficult decision to move to a care facility, the dementia care specialist will provide support across the journey with dementia. Next slide, please. It's important also to know that dementia care specialists are not state employees. They are county employees of the Aging and Disability Resource Center. ADRCs have a contractual relationship with the State Department of Health Services to provide a variety of programs. The DHS provides oversight of the DCS program and provides training to the DCS in support of the goals of the program. An annual research day is held in partnership with our Wisconsin Alzheimer's Disease Research Center to provide education and information that ensures the dementia care specialists understand the latest developments in research and treatment. And as we know, there have been some new treatments that have been released, and people want to understand what that means. So, making sure that our DCS are fully up to date with the reality of the science so they can also debunk the things that are often out there on the internet that may not be true. The Department of Health Services also meets, so the dementia care specialists also meet in regional cohorts to discuss the challenges and solutions to the more difficult issues that they face as a different geological, a different geographical region of our state. Our state is actually pretty big geography-wise, and the variations that happen between the different parts of the state have an impact on how local systems and local resources can be used to provide support. So they work together amongst themselves in regional cohorts, but we also provide a twice per month meeting where the entire program is convened, where we provide updates, information, guest speakers to provide training on specific topics, and technical support around the program itself. And when new dementia care specialists begin, they are matched up with an experienced dementia care specialist who will act as a mentor. Because a lot of the work that dementia care specialists do with families, there's not some kind of a manual or a checklist that tells you everything you need to know to be able to answer everybody's questions and deal with every unique family's situations. And so working together with an experienced mentor to help figure out how to navigate the different systems that are available, the supports that are available, and what would fit best with this particular family's situation is an important function as well, because there are some things that just can't be taught by reading out of a book. And so that learned experience is very important. Next slide, please. So Wisconsin's Aging and Disability Resource Centers are the front door to our Medicaid long-term care programs. However, only about 10% of the programs at the ADRC, or only 10% of the customers that come to the ADRC, will enroll in one of those programs. The majority of services provided by the ADRC are intended to support older adults and people with disabilities that are living in the community. Older Americans Act programs such as benefits counseling, nutrition support, and supports for family caregivers are provided by the ADRCs. In Wisconsin, we have the Alzheimer's Family Caregiver Support Program that is specific to family caregivers of people living with dementia and is a wonderful complement to the National Family Caregiver Support Program. These two programs provide funding that can be used for respite care, home modifications, and other services to support family caregivers. The ADRCs also provide information and assistance in connecting to local programs and supports, as well as options counseling to assist individuals and families in sorting through all the possibilities that are out there. It can be overwhelming to find support for a loved one, and ADRCs strive to be a one-stop shop for everything regarding long-term care support in the community. Next slide, please. So a couple of stories of the DCS in action. So I mentioned memory cafes earlier, saw them mentioned in the chat. For those who might not know, a memory cafe is a space where individuals with dementia and their family caregivers can gather to be social and enjoy each other's company and the company of others in a place that is free from stigma and that they feel comfortable in, regardless of what their behavioral symptoms may be. So, a memory cafe can be anywhere. It doesn't have to be in a cafe, but of course, food always helps with a social event. Um, but they can be at a nature center, they could be at a park, um, libraries, any place really that has space where people already are gathering uh, can become a memory cafe. And there was a memory cafe in the southeast part of our state that was specific to people with younger onset Alzheimer's disease. So people who were younger uh, when their dementia journey began. Many of them still working when they were diagnosed and ended up having to leave their employment when they were still fairly young in middle age. And as I'd mentioned earlier, one of the things that can often happen is friends that may not understand how to support someone living with dementia, how to continue to be friends with individuals and families on this journey. They may fall away. And memory cafes provide a place where individuals who are on the journey together can meet each other and form new friendships. So there was a memory cafe, as I mentioned, where it was focused specifically on individuals with young onset. They they found each other as a set of 6 couples and enjoyed each other's company during those memory cafe events and enjoyed it so much that they began to make arrangements, make plans to meet up and do things outside of the memory cafe. And soon they were going to Brewers games together and they were doing all sorts of social things and continuing to enjoy their communities. So, a memory cafe can be a wonderful bridge for individuals who may find that older friends they've known are no longer accessible to them. And they have the opportunity to create new connections to be able to continue to enjoy their communities and enjoy new friendships. So the Purple Canoe Club, facilitated by a memory cafe. So a wonderful story. And the other story I will share takes us back to one of the catalysts of the Dementia Care Specialist program, the one that involves a person with dementia in crisis. So the adult children of a widowed gentleman reached out to the dementia care specialist in a small city because they were worried about their father. His children described some of the common symptoms of dementia, but he did not have a diagnosis. He had been living alone since his wife passed away 7 years before and had begun to talk to his kids about the neighbors running machinery at all hours of the night. He told them there was heavy equipment like a backhoe digging up the property next door, so he couldn't sleep, although the neighbor's property was untouched. His kids stayed over a few nights to be sure that nothing was happening. Then he began to approach his neighbors, pounding on their door in the middle of the night. One of his neighbors told his kids when they visited that she was afraid of him, but did not want to call the police because they had been neighbors for over 40 years, since their kids were young. Then he began walking in his backyard at night with a flashlight, looking for the source of the noises and vibrations he felt with a loaded gun. No one wanted to call the police on their neighbor. The dementia care specialists were able, was the individual dementia care specialist was able to help the family to navigate the healthcare system while keeping their father safe until he received an evaluation and appropriate treatment after several weeks. Once the cause, which was a contraindicated medication that had been started, was stopped, he stopped having his hallucinations, and the paranoid behavior that resulted from them also stopped. Next slide, please. So some of our lessons learned. As I'd mentioned, we are a very large state geographically, and it's important that the framework of the program that we created was flexible enough to be able to meet the needs in each individual community, let alone county or region of the state. So the three pillars are the framework, but how the program looks from the outside is unique to each dementia care specialist. So building on the strengths of each individual dementia care specialist, which there is a lot asked of them. Not only do they need to be able to do public events and do presentations, they also need to be able to do one-on-one counseling with individuals and families. So there is a lot asked of each dementia care specialist, and as human beings, each has a strength in perhaps one area more so than another. So building on the strengths of each dementia care specialist, each ADRC, and each community is very important as well. Locally available resources and opportunities vary so greatly that one size fits all requirements across the board would make the program less effective. It's also important, and I will talk a little bit more about this, that the program is tailored to individual uh, cultures and individual communities of color. So we also have African American dementia care specialists, we have tribal dementia care specialists, and we have Spanish speaking dementia care specialists in certain areas. And the three pillars, as I'd mentioned, work together to form that web of support. Dementia capable ADRC as the front door to the dementia care specialist program acts as an early detection system for cognitive concerns. And pillar one also refers to pillar two and to pillar three as resources. So when individual ADRC staff are working with the family and the situation may be more complex or the questions are such that they don't know the answer, then they would connect that family with the dementia care specialist. The dementia care, the dementia friendly communities work also provides supportive access to the community for persons living with dementia and their caregivers. It works to make the public aware of the Aging and Disability Resource Center and the Dementia Care Specialist program, and to lower stigma by supporting people living with dementia and caregivers out enjoying their communities. Uh, it's a wonderful public awareness campaign and stigma reducing to have dementia friendly things included with other typical community activities. One of the things, I'm a part of my local dementia friendly community, and one of the annual things that we have are family safety days, where all of our local first responders bring out the fire trucks and the ambulances and have all of their safety equipment and programs on display, having information about, in our state we have Silver Alert or other safety programs for people with dementia available in settings like that, is an example of how awareness can be raised in settings where people would not necessarily expect there to be information about dementia and supports, but absolutely belong there. So pillar three also helps support people with dementia and their families by providing those structured interventions and an individual person who can listen to, understand, and help families sort through complex crises and other situations. So the three pillars really all work together to help support families. It's also important to know people do want memory screening. There are many reasons that individuals do not receive memory screening from their doctors, and the reasons individuals don't want to talk to their doctors regarding stigma as well. But the results from our memory screening in the community pilot study and the subsequent uptake indicate that there is demand for screening that is not being met in clinical settings. Volunteers. Volunteers are so important to extend the reach of that individual dementia care specialist in being able to really fully serve their communities. So volunteers from different communities that are a part of their communities can bring these messages and information and support to their communities if they're given the proper training and support from the dementia care specialist. Local dementia coalitions have a major impact on dementia friendly work, and partner organizations are also so important in taking on some of these activities and some of these um, awareness events as well. One example that I have to share from, again, my dementia friendly community is one of our local bank chains that's local to Wisconsin. Uh, an individual was very passionate about providing training to the banks around how best to understand the needs of their customers who may have dementia. And not only did she train her own bank and their staff, it was so well received that they provided her the ability to go and travel the state and to train all of the branches and all of the employees in all of their branches across the state. And so, helping to catalyze and support individuals who are in a position to be able to provide that information and training in settings that we may not be able to reach into is public health or as an aging support service or community provider. Again, look for volunteers and support where you find it. Park and rec departments are great. The YMCAs are great. And again, libraries are great. Look to your communities and you will find wonderful partners to help support this work. So another lesson that we learned is that starting up the dementia care specialist programs in the tribes, we had some pre-existing ideas that we found out fairly quickly were wrong. um, and that the evidence-based program requirement that we had with the dementia care specialists at the counties, we were hesitant to include for the tribes. And it turns out that the tribes are absolutely fine and really great at doing evidence-based programming, and there's no need for hesitation on that front at all. So there may be some things that you have as preconceived notions about how certain communities may receive these things that you'll find out are not necessarily the case. And it's important for the next one as well. Plain language and names are also very important. So the terminology around dementia is confusing for people who are not involved in this work. And there are many different words that are used interchangeably, and including within the DSM, it's major or mild neurocognitive disorder, which doesn't sound like dementia to me. So it's important to use plain language to help people to understand the information that we would like to share. It can get very complex and complicated. And so keeping the information in an accessible way and at an accessible level is very important, avoiding clinical or technical language whenever possible in all materials. Um, so as an example of this as well, we originally called it cognitive screening and got feedback from the dementia care specialists that people didn't know what that was, didn't really want cognitive screening. The word cognitive was a non-starter. So it became memory screening. Now, the screening involves more than just memory, but that was the term that was most acceptable to people. And so that's what we've switched it to. And the dementia care specialist is called a memory care coordinator when advertised in one of the tribes. because in that particular tribe, the term dementia care specialist was confusing for people. Brain health events are also better attended than dementia education events. So it's important to pay attention to the language that's used, even if accurate. Trying to find language that's the most acceptable is very important as well. And the last of the lessons learned are that family caregivers are the ones that use the dementia care specialist program the most. People who may not have a diagnosis, or people doing the best they can until something happens, and people who do not want help but then hit a crisis and must accept help. There are very, very independent and proud people who live in Wisconsin who do not like to accept help. And so that is another obstacle to the program as well, in working with families and individuals over time to gain that trust, to be able to provide the support that they're willing to accept is very important. Um, and not everyone may understand the critical role family caregivers play in supporting people with dementia, but the majority of time with this disease is spent living at home. And in Wisconsin, family caregivers provide more than $3 billion in care for people each year. Next slide, please. So can you go back? I actually have the secret reveal that I wanted to share with people, and this was involving the one site dementia care specialist program evaluation. So in the southeast part of our state, the Hispanic Health Resource Center, which is attached to a local hospital and is part of a health system, has been in operation for many, many years and is very trusted in the local Spanish-speaking community there. They've served their area with education and services to support healthcare needs uh, for many years again. Training of the staff on dementia-specific education and information, which they did not have as a part of their service package, began in January of 2021. So we provided training on the first and third pillar of the dementia care specialist program, because as you all remember, we were in the middle of a pandemic, and being attached to a healthcare system, they were limited to only providing services online. They were not able to provide any in-person services. Throughout the study, all services were provided remotely online, primarily results that I'm going to share with you after 1 year of service include 39 caregivers. So looking at these caregivers and looking at their health and well-being, we used both the Zaret Burden Scale and the Depressive Symptoms Scale. In the Zaret scale, higher numbers are associated with a high risk of clinical depression. A score above 7 is considered high burden. At baseline, the average score of the family caregivers was 10.4. So 34 out of 39 were considered in the category of high burden. At 3 months of follow-up after involvement with the dementia care specialist, the average score dropped to 8.3, and only 12 individuals were considered to continue to be at high risk for depression. The Depressive Symptoms Scale, higher numbers are associated with higher clinical depression, and a 10 is considered high risk. Oh, I apologize. I'm looking at my notes and I read the wrong paragraph. So as far as follow-up from the Depressive Symptoms Scale, at 3 months, the average score dropped from 16 down to 9.3, with only 2 individuals considered to remain at high risk for depression. So overall, caregivers rated their overall health, with 33% saying that their overall health was poor or fair at baseline. And at 3 months after follow-up, 94% of them considered their health to have improved to good, very good, or excellent. So helping to connect caregivers with those supports improves their overall health, as well as their sense of depression or risk of depression or sense of burden. So in addition to caregiver well-being, we measured caregiver knowledge of dementia and the diseases that cause dementia. caregivers showed a statistically significant gain in their understanding of dementia, and it was reflected in the preparedness for caregiving scale results. Participants had significant gain in the skills necessary to care for individuals with dementia, with the average score jumping from 16.7 at baseline to 22.8 at 3-month follow-up. We also examined access and use of other available community supports for those who receive DCS services. Of the 39 caregivers who met with DCS, 16 were connected with additional community supports. Those included a memory cafe and social programs for all 16, connection to transportation services, which was a big issue for this particular community. Again, all 16. Meals on Wheels, benefits counseling, other ADRC services, in-home care, personal care support, and connection to a long-term care program or adult day services were also a result of the interaction with the dementia care specialist. So in summary, our preliminary data shows that dementia care specialist program provides family caregivers with the tools and supports to improve their overall health and well-being, increases their understanding of dementia and skill in providing care, and connects them with the resources and programs in the community to be successful in their caregiving role. Next slide, please. So the DCS program has now expanded statewide, but it is still evolving. The dementia care specialists have quite a bit of flexibility in the framework of the program to really localize their efforts and grow the program based upon those local needs and opportunities. We have a big SharePoint site where individuals can go to access and share resources that have been developed, so we don't want anybody reinventing the wheel. So as people develop new materials, they are shared across the program. So the need for some of the positions, since we've gone statewide, in the smaller rural areas to be only a half-time position is a new challenge that we are currently learning how to support in doing the work of the dementia care specialist program with only 20 hours per week. So that is our newest learning and evolution challenge. Evaluation of the program as a whole has not occurred. So the information that I shared with you is just from one site and is not a county-based ADRC. Again, that was a healthcare center connected to a healthcare system. So we are looking, and I am hopeful in our next bold application that will be funded, fingers crossed, because we plan to do an in-depth evaluation of the statewide program with the next round of funding. So hoping for that. The biggest impact of the program, I would say, is simply having a structure in place that can evolve with new information and adapts to changes in the landscape of the science and funding specific to dementia as things change over time. It really is a backbone. It's a skeleton that supports the programming and the new ideas and holds space for that programming despite challenges that agencies may face with staffing, because this position is dedicated completely to helping people living with dementia and their family caregivers and has no other duties. So next slide. That is my presentation, and I am happy now to open things up for questions.
Thank you, Kristen. This is a great job. Let's give Kristen and Kathleen and their team a round of virtual applause. Thank you. What a great leading example of how to build really a public health infrastructure with this program and extended outreach. I'm so impressed with, I'm sure everybody here with them, with the connections and the partnerships that continue to be built with this program, and especially with some of these innovative partners like banks and public schools at different ages since early on, to really extend this work. Great job. Thank you so much. And thank you for breathing life into this story and to really what it looks on the front end by sharing that Purple Canoe Club story and the neighbor who was able to connect to access to evaluation services. So great work. So we have some questions now in the Q&A. And I would like to just start with one kind of bigger picture question before we go to the three we have so far. But could you tell us a little bit about the structure at the state level in Wisconsin regarding dementia care and support? What does that look like?
Yes, so thank you. So we are very fortunate in that I'm a part of the Office on Aging in the Bureau of Aging and Disability Resources, and my bureau is within our Division of Public Health. So we really have structurally combined our public health programming and our aging programming. That has really gone a long way to helping bridge some of those connections and partnerships that I talked about between Older Americans Act programming and other activities that can, be done by community health workers and public health departments. So our structure is I am the dementia specialist is my title, but I guess dementia care coordinator is what's being used to represent this position in other states. I work as part of a team. I do not oversee the dementia care specialist program. Uh, I actually have not been the program manager since 2014, even though I created the program. So there are two offices in our Department of Health Services that oversee, in a sense, this program. There's an office that oversees the Aging and Disability Resource Centers, and then there's the Office on Aging, where the manager of the Dementia Care Specialist program is situated. So it's necessarily bridges those two worlds based upon our structure at the state. We also uniquely have combined our two-person dementia team on a supervisory level with our adult protective services unit and our demography unit. So we have wonderful connections in being able to provide support to our adult protective services teams related to individuals with dementia, as well as have the greatest data that we can to be able to make our case. So our structure is a bit unique.
Thank you. Thanks for that overview. We did have one question from Carolyn McGraw. It is in the chat. I don't see it here later in the Q&A, but Carolyn asked, is screening geared towards Alzheimer's disease only, or does it include screening for other dementias such as FTD?
So our screening program uses the animal naming tool, which is a categorical fluency tool, as well as the mini cog, which is basically recall and a clock draw. So the answer, is it geared towards Alzheimer's disease? Yes, it is. It's intended that those particular tools were chosen because our aging and disability resource centers are not clinics, and the individuals who work there needed to be able to use those tools without having any kind of clinical training or background. And so that is largely why I talk about those tools as communication tools. They really facilitate a conversation where additional information is gathered beyond just the results of those two screens. Those two screens are super simple to complete, but they only touch on a few areas of cognition, and those are the ones that are more Alzheimer's related than other types of dementia. If somebody had a frontotemporal dementia, they would do fine on our screens, generally speaking. So part of the program, again, is that conversation. Are you hearing things from that person or from their family that indicates that there is concern going on that may not have been detected by those two simple screens? So that's why the training of screeners includes information about other types of dementia beyond Alzheimer's and what other symptoms they might experience or see that give them a sense that, it does sound like you should talk to your doctor, which is the outcome of our screening program. We suggest make a referral to talk to their physician or not. That's all it is. But it's
Oh,
really a conversation that provides a lot of education and support and encouragement.
mhm. Great. Thank you. We have a couple of questions here from a couple of participants about the program itself, features of the program. So I'm going to read them to you. There's several questions here, but if there is a material or link resource that you can point us to, and perhaps Kathleen, you have dropped this in the chat earlier, please just redirect attendees, and Kirsten, feel free to respond. Several questions. Do the DCSs receive compensation? Are they paid for both education and one-on-one family consultations? What is the average wage range? What criteria is used for selection and hiring? How are they evaluated?
That was a lot of questions, so you're going to have to
Yes.
help me remember what they all were. So the requirements for who it is that we hire as a dementia care specialist really are around their passion and their experience. We require that people have at least 1 year of experience working with people with dementia, and having taken care of your father does not count. This needs to be a series, this needs to be more than one person, because as we all know, if you're taking care of one person with dementia, then you only know about what it's like to take care of one person with dementia. So we need people who have experience with multiple different individuals. And also, just as a part of hiring is a need for a college degree. However, based upon experience, that can be waived. And we have found, especially within our tribes, that we waive that every time and really need to choose the person who has the passion and the connection and the knowledge within the tribe. Really, we want the tribal member themselves to become the dementia care specialist. Somebody coming in from the outside to be the dementia care specialist does not work as well as having a tribal member become the dementia care specialist. So we really want to support whoever that person might be within the tribe with education and training and whatever they might need to be able to provide that service for their tribal members.
Yeah, great.
What were the other questions?
Yeah, change from within the community. And we have a question here from Sam, the Alzheimer's Association. Thank you, of course, for a great presentation and a very promising program. If you were to start the program, the DCS program again, what is the one thing, if there is one, that you would do differently or would improve upon?
I think this is probably a retrospective answer, with hindsight being 2020 and having learned a lot over the past 10 years, but I would probably put a lot more emphasis on the social determinants of health and brain health and prevention than I started with. We really were focused more on individuals who already had the disease and those who are caring for them than more of the lifespan approach that we have now. And I think the other question that I remember is about compensation. So I just want to address that quickly. So the dementia care specialists, again, they're not clinicians, so they're not billing insurance. That's not how this program works at all. They are employees of the county paid with general purpose revenue tax dollars from the state.
Mhm.
So there's a contract from DHS to the ADRC at the county, and that's how the dementia care specialists are paid.
Great. Thank you. Thank you. A couple of links are requested. Are you able to provide a link to the two screens, the mini cog, I believe you mentioned, and the animal memory naming tool?
So Kathleen, are you poised to pop the memory screening and the community manual in the chat?
It is there.
All right.
I know that a number of states have really looked to Wisconsin's DCS program as a point of reference to adopt it, adapt it for their communities. And it really serves as an example of building really this public health approach and putting an infrastructure in place. What are some other lessons learned to those public health agencies here with us today? What would you like them to leave here thinking? What are the couple of things that you would like them to remember? Basically.
So I would like them very much to think about the community health workers they may already have that are working with the older adult population, and adding perhaps some specific additional tasks, I would say, or basically the program result from the pilot that I talked about. Again, the Hispanic Health Resource Center was already using community health workers to reach into the Spanish-speaking community in that part of the state. And because they were already working with the population that was at risk for dementia or providing care, they were a trusted agency and a trusted resource by the community already. So that is very difficult work if you need to build from scratch. But if you can partner with agencies that already have that connection and that trust within a community, and then enhance what they're doing to help them to include dementia care and support for caregivers into their already existing lines of work, uh, that has worked very well. I would also encourage and say, don't try to do it alone. Whatever it is, connect with your aging programs. Every state has Older Americans Act programs in their state and an aging unit at the very least. Most states have area agencies on aging that are wonderful resources to provide that connection with individuals who are seeking out those programs and services that may be under that umbrella and not the public health umbrella, but absolutely are the same people. So it's challenging to try and erase that imaginary line that seems to exist between aging programs and public health programs. But people, they don't hit 65 and suddenly they don't need public health anymore, or all the things perhaps that are available in the aging world, they need sooner than 65. So having that bridge happen for people as they progress across their lifespan, where all these, these barriers and these differences, we can't serve you anymore because of X, now you have to go over there. Those things we have imposed with the programs that we do. So trying to help erase some of those differences, those silos, those barriers as people progress through their lives is important.
Yeah. Importance of partnerships in this work. Thank you. A couple of questions here have come in. Do you partner with community health workers at FQHCs? Do you have?
So we, in our current BOLD grant, actually partnered with the statewide association that the FQHCs relate to. And we learned quite a bit about how they serve a very specific population. And as they explained to us, tends to be younger and uninsured. And we explained to them, there are people who still, may be younger and uninsured for whom this may be valuable information because they're providing care for a relative or because they themselves are experiencing younger onset symptoms. So we have partnered in the sense that we've worked with them to create educational information for their clinics around the need for understanding dementia and community resources, and that this does affect younger people too.
Mhm. There's another question. This is related to the interventions, the programs that DCS is actually deliver or provide. Could you share a link to the dementia support across the lifespan? We have cultural communities with multi-generational homes and all are caregivers to the elders. Can you share some evidence-based, some evidence-informed programs that and promising practices that are used throughout this program? Is there maybe a link, a page that you can refer us all to look at?
So Kathleen can put in chat the link to our Department of Public Instruction curriculum. That's what we have available for younger people. And it's something where you'll need to fill out a brief survey, but then you'll have access to the curriculum itself. So if you are in a state where you would like to have brain health and understanding of dementia and risk reduction conversations happening in your public schools with younger people in their health classes, you can take that curriculum and approach your teachers and offer it to them because it's free for use by anyone. As far as an evidence-based program that works with individuals across the lifespan, meeting children all the way up, the one that comes to mind off the top of my head is the New York University Caregiver Intervention. That is one of the original ACL grant-funded programs that helped launch the DCS program. It is a series of 6 meetings, and it includes in the 4 meetings involving family, anybody that family caregiver wants to have involved, including kids. So it is an intervention that includes anybody across the lifespan in that program itself. I'm sure that there are others that I'm just not going to be able to pull up off the top of my head, but there definitely are evidence-based caregiver programs that focus on a family, and that also includes children.
Mhm. Thank you. I'm realizing now that there are questions also in the chat. And a lot of great feedback for you for your work. There's one from Robin Fraser, and this is back on the topic for hiring and requirements. And Robin is wondering, are you waiving the college degree for other cultural communities to encourage uptake and applications and wider reach?
We haven't had to. It's only been the tribal communities that have needed to have that educational waiver. The other communities that we've been working with had individuals.
Mm-hmm. Okay. I think I'm trying to look through the chat if anything else, but if there's anybody who would like to ask a question or who would like to share their own experience, something that they've done similar in their state that has worked, please unmute yourself and share your story too. This is our time to build this peer learning community. Any similar work, whether it's with dementia care specialists or community health workers, or similar role in the community that you have in your community that you think would be valuable, some lessons learned there, feel free to share with the group. And there is one question here from Victoria Parker, which was about lessons learned that maybe a few minutes ago you already addressed. This is a great example of PSE, policy, systems, and environment change. Can you recommend a first step for states to consider?
So it's the one thing that I would be able to say to talk about as far as how to get started is maybe around the dementia-friendly community work. And also, if you can identify an agency or agencies or partners who are already serving the communities that you would like to target to begin with. Also, um, start small. Don't go statewide. Our program started with 5 positions, so pilot, start small, and go for the easy wins first. If you have a community that's already involved in doing things, or has a physician champion, or things that may be happening already, engage with them first, and always be learning and evolving. Start small, low hanging fruit, and evolve as you go. Um, so finding those agencies for pillar 1, developing your dementia coalition for pillar 2. And the coalition is of the willing. It's of whoever is passionate or interested or wants to help in any way with supporting people with dementia and their family caregivers in the community. Building that coalition is very important for that. And then investing really in some evidence-based programming, or in individuals who can provide that one-on-one support with an individual or with families, because every family situation is unique. Every person's experience going through dementia is unique. So often you hear about, oh, I need some help with something or other related to dementia, and people will send you to a website. Now, that's not always the most helpful way for someone. And as it was explained to me by a family caregiver, he's like, I needed someone to help give my wife a shower. This is one of the most intimate and personal things that I could ask someone else to do. I didn't want to go to a website and like throw a dart at the page and, that's who it's going to be. I needed to talk to somebody and hear about what the options were, you know, how this might work for me, and have a conversation about it, because it was a very important and big decision for him. And so just going to a resource list doesn't cut it.
Mhm. Yeah. We have about 3 minutes left, and I did notice that Kathleen, you had raised your hand in the Q&A to answer a question. It was one related to this 2 screens we talked about earlier. I'm not sure if you wanted to mention anything, but if not, would be great to hear if you have anything to add from your perspective, kind of from the bold work, how this aligns with the other projects, how it supports them. So wanted to give you a chance to.
I think the most beautiful thing about the dementia care specialists is that they are such enthusiastic and knowledgeable partners in our dementia state plan, as well as helping us achieve many of our goals in the BOLD program. They are the people with the boots on the ground. They know people in their communities. They live and breathe this work every day at the grocery store, in their dementia-friendly community work, in their volunteerism. They know all the right people, and they are living the experience. And so they are just incredible, valuable partners to us in going through the community. So I have to say that it's an honor to know them, and their creativity and their passion for their work. So they really are unique and wonderful people. And they also, Kristen mentioned mentoring. They do a beautiful job of mentoring each other. And we often have conferences that are best practices or most difficult case conference discussions, where we learn about unique experiences that the dementia care specialists have with the people in their community, and we all learn from those. So I think those are some great parts of the program. So thank you, Elma.
You are welcome. Thank you. And thank you, Kristen. Thank you, Kathleen, for being here with us today. This was a great session. And Thank to all of you who are all of those of you in the audience who are still there. We hope that you found this useful. There's been a lot of exchange here in the chat, and lots of good resources. We will share them together with the recording and the materials later via email within next 7 days. Please connect with us for any follow-up questions, any more details. If you would like to connect with Kristen and or Kathleen, please let us know. We're happy to help you make that connection. And we look forward to seeing you again in July, when we will be hearing from another state. We'll stay tuned to find out who it will be. Please take just a minute to tell us about your experience today. There's a link in the chat at the bottom. And have a wonderful start to your summer, everybody. It's a pleasure to see you all here. Thank you, Kristen. Thank you, Kathleen.
Thank you.